Hello, everyone, and welcome back to Adventures Through the Mind. This is a podcast that explores topics relevant and related to psychedelic culture, medicine, and research, and always guided by the underlying question of how can we work with and through our psychedelic experiences to become better people, not just for ourselves, but for all those with whom we are nested in relationship. Part of becoming a better person, I suppose, also includes wanting to feel better in life. I guess another way to put that is to get better at feeling, but that's a whole other topic. Maybe it's actually kind of related to today's episode because we're going to be talking about psychedelics as a treatment for chronic pain. So feeling better in the sense that we have less chronic pain and getting better at feeling, as the episode is going to, this interview is going to explore, is getting better at the neurological, the nervous system and the brain mechanisms by which pain is experienced or dampened. That's not entirely how I intended to start the episode, but here we are. And yes, so we're talking about psychedelics and chronic pain, and we're talking about that with Dr. Alex Bekker. Dr. Alex Bekker serves as professor and chairman of anesthesiology at Rutgers, New Jersey Medical School. With doctoral degrees in both biomedical engineering and medicine, he completed his anesthesia training at Columbia Presbyterian Medical Center before joining the NYU Medical Center in 1995, where he later became vice chair for research. An internationally recognized expert in proprioceptive medicine, Dr. Bekker's extensive research focuses on brain protection, neuropharmacology, and pain control. His credentials include 120 peer-reviewed publications in prestigious journals, 6 U.S. patents, 40 educational reviews, and over 200 abstracts. He has led numerous clinical trials, including National Institute of Aging Studies, serves on 5 journal editorial boards, and in 2017 was appointed chair of the New Jersey Department of Health Medical Marijuana Review panel. Relevant to the interview you're going to hear today, he is also senior author on a paper titled Psychedelics as Novel Treatment Agents for Chronic Pain, Mechanisms, and Perspectives. And that's what we're going to be talking about today. Not the paper necessarily, but the topics the paper explores. We're going to be going into a deep dive on what chronic pain is and how chronic pain differentiates from acute pain, how chronic pain is related to what Dr. Bekker describes as maladaptive neuroplasticity, and how it is that psychedelics may be effective in treating chronic pain conditions that we presently have no completely effective drugs or therapies for. Personally, I feel like I learned a lot from Dr. Bekker in this interview about pain and chronic pain and where psychedelics fit into that, and I imagine you will too. Although if there's a specific topic that you want to zoom in on or sort of like target in your listening, I always include timestamps / chapter markers when I release these podcasts, be it through iTunes or Spotify or YouTube. So you can look down in the description and you'll see a list of all the topics so that you can go directly to whichever one you're most excited or interested in. But that is irrelevant to those of you who are interested in just listening to the whole episode anyways. And that's it for the intro. So let's jump right into our interview here with Dr. Alex Bekker on episode 196 of Adventures Through the Mind. Enjoy. Dr. Alex Bekker, welcome to Adventures Through the Mind.
Thank you, James. It's my pleasure to be here. Topic close to my heart, so I would enjoy this interview.
So we're going to talk about chronic pain and psychedelics as a potential treatment today. But I want to start it off with getting a sense of, I guess, like what neuropathic pain is. So you can maybe bring that in with chronic pain. Basically, what it is, its impact on people's lives and its impact on public health.
Yeah, I understand the question, but before we go to chronic pain, I want to spend a couple of minutes to ensure that your audience sees the difference between nociception and pain. Nociception is a physiological process which let our brain know that some part of our body is in danger or actually injured. So how it goes, you injure, let's say, your tau, and we have molecules or substances which call nociception. They perceive this painful signal and transduct this signal through nerve to spinal cord, and this is called primary nerve. And how conduction goes, we have lots of what you call ion channels, which opening up and down and propagate action potential. So it goes from primary neuron, and on a level of spinal cord structure called dorsal horn, is a secondary neuron there. Secondary neuron which takes signal from there, propagated to a structure called thalamus, and thalamus connected to many parts of the brain. And but mostly in this particular case, what's important to us, to sensory cortex. So this is nociception. This is how nociception transmitted. What we call pain, it's a purely subjective experience. What's painful to you, it's not painful to me necessarily. It's a different experience, how you perceive this signal. This is acute, but usually it's a kind of signal which make us anxious, dangerous, that we know that something bad happening and we need to take care of this. It can be, I don't know, tiger running at us, it can be, or scratching us, it can be fire or whatever it is. So it's a healthy, absolutely necessarily for our survival response. This is acute pain. It was historically developed, teleologically developed, like protective mechanism. This is great. So nociception is different from pain. Pain, it's a part of it's obviously physiological response, but it's current thinking. It's more biopsychosocial model. Lots of social factor and psychological factor will affect your perception of pain. This process which I described, it's acute pain. Chronic pain, it doesn't have this kind of pattern. It's in whatever signal are generated within your central nervous system and peripheral nervous system. And this process is what you call peripheral sensitization and central sensitization. And we will talk a little bit about these two entities because it's important to understand lots of effect of psychedelic actually related to psychedelic effect on central and peripheral sensitization. So chronic, when you, let's say, thermostat, you put on 80 in temperature in a room, it's 80 or 82, but irrespective, it will be sending this signal to continue heating the room. So central sensitivity, let's start with peripheral. It's a little bit easier to understand. If you continue the stimulating part of your body, all initial signal would be exaggerated, and even if you don't have, it's kind of like static in transmission of radio signal, and this nociceptor would be randomly generating this signal, which will be perceived in the brain like painful when actually nothing necessarily happens. They do it on their own, and this is what you will call peripheral sensitization. The same kind of circuits, abnormal circuits, can be formed in central nervous system, in spinal cord, as well as in the brain. And this circuit kind of operate independently of, we will talk a little bit later why we even form these circuits. But at this point, let's assume they form, and this would be central sensitization. These painful circuits persist irrespective if we have actual signal or not. We start having diseased neural network. Our nerve are diseased, and the term neuropathy just simply means pathology of nerve or disease of nerves. So this is what neuropathy. It's not actual signal anymore. Or sometimes it can be mixed with actual signal, but for the most part, it's a disease of a nervous system. Can be peripheral, can be central. And then you have two phenomena described by hyperalgesia and allodynia. What it means then in this, when nervous system is disrupted or injured, uh, normal signal we generally, let's say, touch, which generally doesn't bother us, it would generate painful signal. Everything, it's a hyperalgesia. You respond abnormally to normal signal, which generally body ignores. And allodynia, it's an area which is around, not even injurious area, but because whatever nociceptors, they proliferate, area around the injury start feeling pain as well. All this thing goes to your brain, and normally if something at some point, James, you want to interrupt, let me know, because I kind of have so much to say about
Sure.
this.
Yeah.
So I don't want to kind of take more time than needed. But what's happening in normal circumstances, when we have painful stimuli, brain also generates what you call descending inhibitory signal. A brain sends signal to the, in this case, it would be dorsal horn or any place where this synapse, primary and secondary synapse connecting, and send signal to slow down, to reduce this transmission of painful stimuli. And this best we see like in acute pain model, let's say soldier in the middle of a battle, they injured, but they truly don't feel pain, because this inhibitory pattern relieve endorphin and other chemicals which reduce intensity of a signal which goes to your brain. And this is again critical in understanding of mechanism of action of psychedelics. So inhibitory pattern is critically important, and it's disrupted in chronic pain or neuropathic pain syndrome. You also, in chronic pain, in some condition, have inflammatory component. And inflammatory component, it's not necessarily in your periphery. It can be inflammatory component, like our nerves are surrounding by what you call glial cell, which is support nervous system, and they have macrophages, and so you have, in addition to regular inflammation, you have a neuroinflammation, inflammation of a neural network. All thing is disrupted in chronic pain condition. How big is condition? From not how big, probably wrong word, how prevalent is condition? In general population, we have about 25% of people can be diagnosed with chronic pain, and about 8 to 10% impactful chronic pain which really disrupts their lifestyle and things like that. Again, in some group, and we will, I guess, a little bit later talk about condition, chronic pain, it's much higher in diabetics, in people with chronic inflammatory disorder like rheumatoid arthritis, and condition. Actually, it's interesting. I need to bring it up because it's such a great illustration to what I was talking before. Condition like phantom limb syndrome. You don't have a leg, but you perceived pain like it's a real pain. And so obviously, for whatever reason, they lost their leg. Most of the thing is secondary to diabetes. So prevalence of chronic pain in diabetic patient would be much higher, and in some kind of other diseases, some other diseases as well.
So let me jump in and see if I can get a general sense of a couple of things. So when you're talking about chronic pain, you're talking about something that is in the nervous system. It's not necessarily like, oh, my knee is hurting a lot because I have a particular injury, and so it's like chronically kind of sore because I have this particular injury that hasn't healed. You're talking about something that isn't necessarily related to like an orthopedic injury, but a kind of injury to the actual nerves in a particular part of the body, which sort of over time damage the nerve tissues themselves, so that either at the site, locally at the site, there's pain in the nerve cell, or that damage in the nerve or in the sort of like nervous system or even in the brain can move centrally into the central nervous system. And so that same kind of damage either exists locally at the space or like in the central nervous system that disrupts like kind of pain signals globally throughout the entire body. Is that correct?
Yeah, in some part of it's correct. Truly, you don't your injury may be healed, but nervous system get damaged. But one thing I need to correct: you don't need to actually injure. You don't need to cut your arm in the middle to cut nerve. This maladaptive, let's start introducing this was maladaptive neuroplasticity occurs irrespective of actual injury anymore. So it's our brain keep changing during the lifetime, new thing you learn and whatever. And this is, our brain is plastic. You can change brain. And in this case, I need to go a little bit off and explain something somewhat advanced, but I would say interesting. In resting state, just like normally when you with your own, we have a network of interconnection between various parts of a brain called default mode network. What it means, this is a network which is responsible for self-referential processing. You know that you are. It's mind wandering and assessing situation. This is what you are. And we have in resting state this type of continuous activation. This is what they see on functional MRI. Even if you just relaxing, you still will have part of a brain connected. What happened in chronic pain from these continuous signals, you start changing this, your default mode network start including connection, which is not part of it. The new connection, which is related to chronic pain. And your referential state, already you will be ruminating about your painful stimuli, make things worse, you'll be miserable. Your network normally clean, normally out of this thing, all of a sudden start including this new connection, and your default mode will include this connection. You will be thinking about it. So what's, let me give you another example. Let's say you have some pain, I don't know, toothache, and then you're watching a movie for 2 hours. For these 2 hours, you forget about your pain. But when movie is over, oh my God, it hurts. So when we from this default mode network, we need to move to task positive network. When your brain occupied with something else, you may if actual pain even exists, for a while it wouldn't be part of it. You're focusing on something else. This is actually interesting. It happening partially with psychedelic, but definitely with cannabis. If they have a pain, if people have chronic pain and they treat it with cannabis, if you ask them, can you tell me what's your level of pain? They say, yeah, 8, 9, but it doesn't bother them. The network is excluded. This new connection is not part of your default network, so-called dissociative analgesia. Part of it, we will get to it when we start talking about mechanism of psychedelic, but generally I want important concept to see here, that our default mode network includes abnormal connection in chronic or neuropathic pain patient. And we need to figure out how to break it.
So I'm hearing you talking about these sort of like, it's almost like multimodal chronic pain. So you may have an injury associated with the pain signals, or that injury might be gone, but nonetheless, there's a damage that happens to the nerve tissues, either in the peripheral nervous system, which I'm interpreting as kind of like locally, or it can move to the central nervous system, in which case it's like you have a global sort of dysregulation of pain signals, and that over time can sort of, through neuroplasticity, change the sort of like way your brain, the way you think about yourself, the way your just like general default perception is including or excluding pain, such that you might like remap your sense of self to be sort of centralized around the ongoing perception and impact of pain, which would mean now it's not just a physical experience of damage to the nerves, it translates out into a psychological experience of like how we perceive ourselves in our lives and our ability to do things. Because if I can speak from personal experience, like if I have pain, it's very hard to focus on something or to think about things positively if I'm constantly experiencing pain. And so in a chronic pain condition, I hear you kind of saying there's this nervous system aspect, peripheral or central. There's this inflammatory aspect, which I assume sort of compounds the nerve pain. And then you have this kind of remodeling of neural networks to sort of include this pain and its impact psychologically, and then of course behaviorally and socially, in the sort of like networks that are kind of like at the root of who we experience ourselves as being when we're not engaged in a particular task. Is that about right?
Where you put it, it's excellent. I'd be happy to record you. And it's like, in summary, you said exactly right thing. It's a multifactorial phenomena. And when you approach dealing with chronic pain, it's not one thing. It's it's a psychosocial mode. It's everything is changed, like cognitive behavior therapy. Why it works? It's not biological signal. It's not changing. So something we're doing, it's going to this default mode network, and neuropsychologists probably will tell you much more than I can do about. They're talking about that. But generally, yes, there's several things you have to change to get rid of chronic pain. That's why when pharmaceutical company developing another, okay, we have this new drug, I know from the beginning it would go nowhere. It's just one aspect of whole thing. We will talk a little bit more. Maybe we should move how we treat chronic pain right now.
That is my next question. I was waiting for you to finish your summary, but I am curious, what are the current treatments for chronic pain? And I guess how effective are they? Because you just said, like a pharmaceutical company comes out with a new treatment and you already know like it's not actually going to work. My assumption is there's a good chance that it will work somewhat for some amount of time, but it won't fix the problem. So maybe you could give us a little lay of the land for treatments.
All right. So again, let's start with acute pain. In acute pain, you have to somehow stop signal from propagating from a site of injury to the brain. So how we can do it? We have one absolutely reliable method is give opioid for acute pain. And I kind of cannot emphasize this more. Opioid works for acute pain when you have to stop, or drug like lidocaine, local anesthetics, they stop transmission of a signal. This will help, temporary help. It's not help. Temporary help is acute pain. So what we have for acute pain, non-steroidal. We have Tylenol, which is there, but it's very minor kind of player. It holds this thing. We have local anesthetic. We have regional, and this is all work for actual, during the surgery. So you can add ketamine to it, but it's all element of acute pain. So when people develop chronic pain, if you don't have deep understanding, what first comes to my mind, let's try to use the same medication. Why not? Mm-hmm. But an initial stage of chronic pain in many situations, it's a transition from acute to chronic pain. If you treat acute pain and subacute pain, acute pain generally up to 4 weeks, 4 to 12 weeks. Subacute pain, more than 12 weeks, you define like a chronic pain. So in initial stages, this drug can work, and this is usually part of the algorithm. NSAIDs and steroids and things like that, Tylenol, local anesthetic. This is initial stage. When you get to truly chronic pain, these drugs are useless.
Mm-hmm.
Also, people, an actual recommendation of International Association for Treatment of Pain, or maybe something like this. It's a major organization will define pain and things like this. They're not recommending opioid because they don't really work for chronic pain. People traditionally kind of feel like, oh yeah, let's give opioid, but they don't really work. You need something. Then current algorithm for chronic pain treatment includes a centrally acting drug like amitriptyline, gabapentin, doxorubicin, and things like that. So they all, if you see the pattern, they're not peripherally acting drug. They're all centrally acting drug to change something in our brain, or enhance descending inhibitory pathway, or drug which can change synaptic connection between, and this I have to kind of go tiny bit detour. How nerve communicate? We have a nerve cell, and we have a connection. On one side, we have a dendrite which perceive pain can be from outside or internally, perceive pain or any other sensation. It goes to cell body, and then it goes to axon, which transmits the signal to next neuron. And how neuron communicate? You have a synapse. Axon releases some neurotransmitter, which can be serotonin, dopamine, norepinephrine. It's a whole bunch of these neurotransmitters are still connected. And dendrite of next neuron perceived this they have a receptor for this neurotransmitter, and if receptor is correct, if dopaminic receptor is on a dendrite and dopamine is released, and it's a lot of it, dendrite would know, oh my God, it's a lot of this signal, I need to quickly, and then they propagate further. So the synapse is extremely important in understanding how these drugs work, because many of them will work on synapses. So James, refresh my memory.
Yeah, so you were talking about like acute pain generally gets treated with things like opioids or NSAIDs,
treatment of pain.
And then you were getting into like things like amitriptyline and gabapentin.
Yeah. Right. Which is centrally acting drug. For chronic pain, one of the most widely used recommendation is cognitive behavior therapy, mindfulness. Again, people understand that just by treating and giving some chemicals, not necessarily would your disease, your pain would not be cured necessarily. You need something else. You need to change your default mode network, and this can be done whatever modality you find, because some people believe that transcranial magnetic stimulation will do it, cognitive behavior, mindfulness, some drug can temporarily, and now we're getting into psychedelics, how they actually work. One of these, and in my belief, one of the strongest.
Wait, pause for a second before we get into psychedelics. Yeah. I just want to clarify something, because you were talking about the sort of like neurons and the sort of action potential and the firing and the neurotransmitters. Yeah. When you talk about the drugs that are used centrally to reduce chronic pain, they're trying to treat the pain signaling, the dysfunctional pain signaling complex by kind of convincing the neurons not to fire at the presence of pain. That's where things like amitriptyline and gabapentin come in, gabapentin being working on the GABA system to sort of inhibit the firing of these things. I assume you were saying it was like down something inhibition, it's sort of increasing
on the synaptic level.
On the synaptic level.
So this drug would be interfering with transmission of this internal signal. So when I said primary, secondary, in reality, before you start perceiving, it would be 10 other interneurons there.
Sure.
Depending on a drug, it can suppress this transmission, and this is how generally centrally acting drug work. Like amitriptyline, we reduce norepinephrine transmission, or gabapentin would be on GABA receptor, increase or decrease glutamate. We have the same chemicals, the same neurotransmitter. In some place it would be inhibiting, in some place it would be exciting, and the nervous system too complex to figure out what happening there. But generally, concepts is there. They're working on this transmission of a signal from one neuron to another. You will reduce perception of pain. None of this drug can actually change interconnection between different parts of a brain. None of them.
And my anticipation is, although some people will find some solid efficacy for certain periods, maybe long periods of time with these drugs, otherwise they wouldn't be used if they just didn't work. But all of these drugs at some point, they kind of get you on the treadmill of needing to like progressively increase your dose in order to have its sort of efficacy. My assumption is at some point, like they all kind of stop working if that's the only avenue of treatment is just, the central drugs. And that's where things like cognitive behavioral therapy come in to kind of like as an adjunct to that. But my anticipation is that neither of those things necessarily, like you said, they don't change like the sort of maladaptive brain structures that have resulted from the chronic pain. So they're all still just kind of attempting to suppress the symptoms of the chronic pain condition. They're not really solutions to the problem of the pain. They're sort of like solutions to the consequences of the problem or something like that. Does that?
Right. It's correct. And chronic pain or neuropathic pain, I say brain is interconnected. Our system, which is responsible for our emotion and social behavior, limbic system, what they call, which includes several structure. Right now, it's not really important. Let's just call it limbic structure, which is responsible for our emotional well-being and anger and everything else. So in chronic pain, in chronic or neuropathic pain patient, this system is connected to prefrontal cortex, which is what we are, and it's sending wrong signal. You establish wrong connection, and our emotion, people usually depressed. Actually, it's very interesting. In my paper, I have a picture, and it shows that lighting of a part of region on functional MRI in chronic pain and depressed people is similar. There's similarity. What's this connection? What's part of a brain are active in a particular point? So people with chronic pain, usually they would be not all of them, but depression is a big part of it. So amitriptyline, actually, it's a treatment for depression, and the same Cymbalta and things like that. But they help patient with chronic pain on the same principle. It starts changing and affecting this connection or synaptic connection between this neuron. So truly address chronic pain. From one side, you need to use this medication, as we said, but at the same time, you need to use cognitive behavior therapy, mindfulness, transcranial magnetic stimulation, whatever you want to establish new connection, and whatever methodology. They believe that transcranial magnetic stimulation is somewhat working in this direction. But for the most part, it's not obvious how to do it. So whatever this therapy, it cannot be just anti-inflammatory. It cannot be just against central sensitization. It should have some psychological component, and maybe quite significant part of psychological component. And you also have to change your default mode network to remodel it and excludes this connection, which are responsible for perception of pain. Not actually nociception, perception of pain, which, as we started with, is two separate entity.
Interesting. And in that, there would also need to be, like, if you're really going to effectively kind of heal from chronic pain or whatever the damage is like, there needs to be some, like, ideally there's something, a part of that whole sort of program of treatment that helps to eventually fix the sort of root of why these pain signals are ongoing. Like, you need to maybe, I don't know, I'm trying to invent something in my mind here, but like reduce everything and like remap your sort of identity and perception enough so that it lays new networks, not just on how you understand yourself, but new sort of like networks for your nervous system so that they're not sending these inappropriate pain signals.
Right.
But we don't have any, seemingly we don't have any really successful drugs or treatment protocols that do that at a a high success rate. And my anticipation is that there's some hope right now, or some evidence to suggest that psychedelics might be able to step into that kind of like lacking treatment vacuum, and may very well be like a highly effective treatment for
it's
chronic
a
pain.
good summary. Actually, let me continue on this venue, talking about drugs. In the last 50 years, we have 100 different, not 100, but many antidepressant. But incidence of depression is not going down. If you're just using drug, it may in some way work for schizophrenia, but for depression, anxiety, yes, they're taking this drug, but they still, they're somewhat sedative, most of these drugs. So it's kind of perception, maybe less acute, but you're still depressed. They don't change the structure of your brain, which predispose you to depression to begin with. It's chronic pain. It's kind of similar. With drugs, actual drugs, you can temporarily reduce discomfort or whatever you have from chronic pain, but inherent issue is still there. Your connection are there. And when you with yourself and not distracted by movie or, having a drink with your friend or whatever you do, if you're not distracted, it comes back. It's there. And unless you figure out how to remove this psychological and social in a way, there are certain, and it's not necessarily malingering. I use this word because I just cannot find better. People have benefit from chronic pain. Usually you feel sorry, you kind of try, oh, honey, I have such a migraine, I will do this for you, I will do that for you. It's not they intentionally telling you, but connection are formed over there. That if you complain, something transiently good will come out of it. Extreme cases is legal. Like if you have a lawsuit against some company because they damage you, again, it doesn't mean that you're actually lying. Not at all. It's internally. It's so ingrained, and the circumstances, social component of it, creates this sense. So when you say everything is in the brain, it is, but pain is still there. It doesn't really matter where it's coming from. Mm-hmm. You feel discomfort, you feel anxious, you feel fearful, you have tendency to catastrophize and things like this. This is especially true with cancer-related pain.
Which is understandable because a cancer diagnosis is a catastrophe
right,
for a lot of people. Right? Yeah.
Correct, but nowadays most cancer are treatable. Yet this perception of catastrophe and things like this make things worse. Nobody wants to have cancer, die or not die. But generally, this kind of thing exaggerate your response, and you form this internal connection. And until you break this connection, physical treatment of pain or pharmacological treatment of pain very unlikely goes to the root of a cause of a problem. Again, one solution I mentioned before, dissociative analgesia. This is very typical for cannabis and ketamine in some way, but it's not exactly what's happening with psychedelics.
Let's take a little second here I want to thank the people who make this show possible. People like you, listeners like yourself, perhaps not just like yourself, maybe literally you listening right now, are responsible for this podcast being something that I can continue to put my time and energy and finances into. I'm talking about my patrons on Patreon and the people that choose to leave voluntary donations to the show per episode. Without your support, this podcast wouldn't exist. I mean, that's not true. Without your support, definitely this podcast would still exist. I would keep making it because I love making it. However, the financial support of my patrons and other people who choose to voluntarily pay for this show, which they otherwise would not need to pay for it because it's for free and openly available, make it so that I can earn a living doing this podcast as my job. Time is unfortunately money. So it means that we need money to have the time to do things, or we get paid for our time in monies. And I am able to continue to give my time, my days, my hours, my life energy, my passion, my excitement, my commitment, my effort to at least trying to better the world in whatever small way I hope maybe I am doing through this as the avenue that I have to have impact, or one of them that I have to have impact, and earning a living doing it. Might have got a bit jumbled up there, just trying to go off the cuff and just say thank you. Thank you to my patrons. I really appreciate it. Thank you to people who choose to donate to the show. I really deeply appreciate it. Thank you. The people whose names you see listed on the screen here on YouTube or in the description to this episode, wherever you're checking it out, give at least $23 a month or more, or have offered a significant one-time PayPal donation. And the credits here, their name in the credits to this episode, are an added acknowledgement for that generous contribution. If you listening right now are finding value in the show, I please ask you to reciprocate that value in some way. The most ideal way for me is through becoming my patron on Patreon and pledging to offer a contribution monthly of a dollar amount to your choosing. Even if it's only just a couple of dollars, it really does make a difference. You can, of course, offer more if you're interested in that, and the more that you offer, there are tiers to which you get extra stuff like your name in the credits. Links to become my patron on Patreon or to leave a one-time donation, which is an awesome way to support the show, are listed in the description to this episode, wherever you're checking it out. If financial means of supporting the show are not available to you right now, don't worry about it. Any kind of engagement online with it, sharing comments, reviews, subscriptions, likes, stars, hearts, whatever, is also quite helpful. So thank you for doing that. And let's get back into the interview, right? Here we go. In your paper, you proposed some, and I want to get a little bit heavier into the psychedelic side of things here. You proposed sort of like several possible pathways that psychedelics can help with the sort of like the multifactorial issue of chronic pain. And so I want to try just like, I will list them like one by one, and then maybe you can explain what that is. Like I'm going to use your words straight from the paper, and then you can explain what you mean by this and how psychedelics come into play. So the first one is alter pain perception by directly activating serotonin receptors.
Right. Classic psychedelics, which include LSD and psilocybin, DMT, partially MDMA. They work on serotonergic system. This is what they call 5-HT. There are like 9 or 10 of these receptors. This particular drug works on 5-HT2A. And what they do, I guess I will call 5 element. One would be they will promote neuroplasticity because these receptors and the synapses, and together the synapses and receptors involved in formation of new synapse may potentially create new connection. So this is part of direct effect of this drug. They also anti-inflammatory component, and this is very well proven, especially for psilocybin in animal models. Serotonin receptor are responsible for inhibiting pathway. They originate in a structure, what you call periaqueductal gray. It's in our brainstem, and most of these receptors are actually both cannabinoids receptor and serotonin receptor. So they enhance this inhibition. They promote synaptogenesis. What it means, you will have more of synaptic connection based on serotonin transmission. They also actually remodeling. End of this dendrite consists of small little spine, dendrite spines, they call it, which actually perceives this signal. So with psychedelics, they again, most what I will talk right now, from now on, it would be classic psychedelics, serotonergic psychedelics. There are other, but right now we know little about them, so let's focus on that. So this substances increase the number of this dendritic spine and enhance the signal just from there, just having more locators, we would say. It enhanced network connectivity. And this is probably a major mechanism by why serotonin receptor will work. It's reduced central sensitization. It enhance inhibition of signal. It's promote neuroplasticity through synaptogenesis. And their minor indicates unclear, but people believe that they activate certain genes which responsible, and this is what you call epigenetic. When you have substances around part of a cell which activate synthesis of particular protein or neurotransmitter, our DNA generally, DNA not working all the time. You activate genes at particular need or whatever it is. So they activate right gene to create new synapses and new connection. So when you create new connection and they kind of reset whatever your default mode network can be reset when you give psychedelics, your core network, your default mode network is disrupted, and at that time it gives ability to form new connection. And pain connection probably still exists, but they wouldn't be dominant. You form new connection. And time, like anything in memory, fortunately, we don't remember all of things, otherwise we'll go crazy, right? So with time, if you not enhance some signal, it will disappear. So it's not right away, but your pain connection, if you form new healthy connection, you start doing something other than thinking about your pain, it's not there. You have something else. You created task positive network, which is more responsible for when you with yourself, you don't think about pain and ruminate about pain all the time. You have other things to worry about or think about, and this becoming more normal. We should be, everybody, stress is part of it. Stress of our life, but when you focus stress on one particular aspect, all other part you neglect, and you're not dealing what you're supposed to do. You keep thinking about pain. So this type of new connection, which is serotonin activations of serotonin receptor would lead to that. How you activate, it's, I wouldn't call secondary. We have a SSRI, which is increased level of serotonin in the brain, but it's only one aspect. Psychedelic works on many aspects of chronic pain. That's why I believe it's would I say it's a magic bullet? Probably not. Like everything right now, way I see it, it's one of the unusual characteristic of psychedelic. They work on many aspects of this chronic pain, biopsychosocial. So they will affect bio, they will affect psycho, and they will affect your social interaction. In this case, I have to bring MDMA, probably the strongest. MDMA, it's not your typical classical serotonergic psychedelic. It has also a component of dopamine activation and oxytocin activation.
And norepinephrine as well.
Right, but in this case, why I'm focusing on dopamine, it gives certain pleasurable feeling, and oxytocin, it's a drug, it's not drug, it's a hormone usually released, let's say, after delivery baby. It's kind of established connection with other person. So MDMA, you have this situation when you feel empathetic to others, and which it's kind of feedback loop. Others feel different about you. But this is, but in other more classic psychedelics have some element of this, but not as prominent like with MDMA.
So I'm gonna jump in. Like, what I hear you speaking to, and I'm gonna kind of refer to my notes from your paper while I'm saying this, is that you're, based on what we know about through the psychedelic research and all the different sort of aspects we've come to identify, and these are the things that these psychedelics do in this context, in this brain, and here's the result. That it's a fair hypothesis that developing a treatment protocol for chronic pain that includes psychedelics might end up being significantly more effective than our current treatment protocols, because they address a number of the aspects of chronic pain simultaneously, on the direct biological level of their impact on the nerve tissue through its impact on serotonin and the perception of pain, but also through psychedelics having, or classical psychedelics having, a direct anti-inflammatory effect, which would, the inflammation is a part of the activation of these nerve cells. And you also said that it'll enhance descending inhibition, so it'll enhance your brain's ability to be like, no, you don't need to fire, like no need for that pain. And it also creates this opportunity where, from the psychological aspect of what we can experience and discover during our psychedelic experiences and whatever therapies and support it, we can have, like CBT can support the efficacy of a gabapentin prescription, we can utilize therapies during psychedelic experiences in order to amplify and reinforce new ways of relating to ourselves and our lives, such that we can maybe not deprioritize, but like sort of take a few step downs, like how prominent the changes in our perception related to chronic pain were. We can put chronic pain far enough down that we can reinforce these other aspects, such that chronic pain can slowly become less and less a part of our default mode network. And this is something that is theoretically reflected in an actual change to the kind of networks in the brain responsible for how we perceive ourselves and our lives. And so in this way, we can address chronic pain on multiple levels, which of course would then change how we show up to the world. We have insights about ourselves and about our pain, about our behavior. That'll change how we behave in the world, which will change how our social world responds to us, which then gets into the social aspect of it. And so there's this one drug, or one class of drugs, can be utilized in a way to target all of these different issues related to chronic pain in a way that actually can make substantial long-term changes that are not dependent upon continued administration of the drug in order to reduce the symptoms of chronic pain. Is that about right?
Yeah, I would say yes, you're right. In 60s, when they start using LSD, It was adjunct to psychotherapy. This is how it was actually used and advertised. It's not by itself. In adjunct to psychotherapy, you have anxiety. Chronic pain was a small part of it. We talk about more anxiety, depression, at that time they didn't use the word PTSD, but one way or another, it's a part of it. So with psychedelic, when they kind of start breaking up your default mode network, psychotherapy will help you to establish new network. Psychotherapists will discuss with you how important it is to have this connection, or I don't mean brain connection, I mean human connection, and whatever psychotherapy issue you're resolving, it will help to resolve. And I think partially this is how it works. Even current understanding, cognitive behavior therapy should be in combination with psychedelics. They do one part, they break and ready to start new connection, but psychotherapists have to help patient to form this new connection. They don't start from nowhere. So you have to, it's a suggestive kind of cognitive behavior, change behavior, and you start forming new connection. But what psychedelic will do, it give you space where you can start forming this new connection. Right. So generally, it should be in combination, and in combination, even with more traditional drug. If you have disease like, I don't know, peripheral neuropathy, you probably still will benefit from using capsaicin or something peripherally, because you're still getting new signals there.
Like a topical pain relief.
Right. Yeah. It wouldn't help you in, like, say, if you have sciatica or something, it wouldn't help you. But if you have disease component, just like, again, diabetic peripheral neuropathy would be a good example. Yes, you still need to take, there it's a kind of mixture. You have a peripheral signal, but you have already lots of central signal there, central sensitization, peripheral. So you will do both. You will do that, and you will use psychotherapy, use psychedelic to clear from disrupt this connection, pain connection, which there, and now somebody would help you to form new connection. Again, this should be emphasized. Psychedelic ideally should be part of overall treatment, not just, again, it's not you take mushroom and you cured. It wouldn't be like that. It should be part of multimodal type of approach where cognitive behavior therapy, mindfulness, or whatever you use, even, but somebody have to tell you what's this connections, that you're missing social part, you're missing this part, you need to reestablish this part, and you to relearn. And psychedelic helps you to relearn this thing. It's kind of brain is, I wouldn't say child. I mean, obviously you have all this thing, but you clear from, you make it ready to learn new thing. And new thing would be critical in establishing this new connection.
I mean, speaking of critical and new learning or relearning, there's good evidence to suggest different psychedelics open different critical learning periods, both in the sort of like soft sense of like critical social learning periods of like learning certain sort of cues or behaviors, but also on the sort of hard end. Like I recently saw some research that suggested LSD opens a kind of like critical learning period for visual perception, which otherwise would have closed long into your childhood, infancy, and even opens up a sort of critical learning period or relearning period, window of neuroplasticity, I believe is a term used in your paper, that is related to like learning, like motor neurons learning new ways of sort of like new patterns of firing, which would then theoretically make it quite helpful in the treatment of things like stroke or overall things like brain injury, which would create this critical reopening, this critical learning period in order to start laying new connections in the brain to do functionally things that were relying on other pathways that were now damaged and are no longer accessible.
It's correct and interesting. You mentioned stroke, somewhat outside of our conversation. When patient has a stroke, let's say he or she or whatever cannot move particular part of a body, but with rehabilitation process, as a part of stroke means that part of a brain is dead. Not much you can do. whatever, for a while you had no oxygen in part of the brain due to interruption with blood flow or whatever was there. So this part is dead. It's not like it will recover, but as a part of a brain, because brain is neuroplastic, will start learning how to, and this is motor one. It's kind of very interesting. Motor everybody sees. So you've been limping, and a year from now you're not limping anymore. This is easy to see, but concept is the same. You you force as a part of a brain by continuous exercises to take over its function. Now let's go to cognitive ability. You can ask brain or force brain or teach brain how to learn new behavior, pain-free behavior. Conceptually, it's similar to your post-stroke patient. You're learning how to do new thing, and brain has enough capacity to, it's not a recover brain, but has enough capacity to do it. The same process, maybe even physiologically, will happen with forming new connection and new, changing plastically, changing a part of a brain. It's kind of, I hope you see the parallel in this.
Yeah, it's like with the the stroke example for movement. It's like if you have a river or something, and the river, well, just say like a little stream, a steady stream of water. If you put a stone in the middle at some point, it's like, oh, it's just not going to flow anymore. But eventually, the water will pool up, and it'll find new ways around in order to keep the stream going.
It's a good metaphor,
right? And therapeutically, that's what people are trying to do in stroke. You're not trying to fix the damaged parts of the brain. That's done. They're gone.
Yeah.
You're attempting to functionally remap at a neurological level, like these physical actions that now need new pathways in order to activate, to fire, to like reach hand, to grip, etc., or to talk, or what have you. And the parallel is that a very similar thing is happening with the possibility of psychedelics for chronic pain, but the sort of new behavior or the new sort of movement that you're trying to educate is like at the very nervous system level of having the brain fire signals differently and interpret signal firing differently. It's not as explicit as, can I reach and grab the cup? It's got a way of trying to convince or train the nervous system, when this sensation is triggered, this amount of sort of activation is now changed such that it doesn't cause chronic pain, or just centrally in the entire nervous system existing is not causing chronic pain. Is that about, did I get that?
Well said, right. Yes. In a stroke model, it's brain learning certain movement. And in cognitive model, it's brain learning certain new pattern of behavior.
Mm-hmm.
In chronic pain or neuropathic pain, generally a goal is not necessarily to cure this pain. Whatever, even if you have actual cause, let's say you have a 5 back surgery, there's not much you can do, but you have to learn how to live with that. And this where a role of psychedelic and reduce influence of this original painful connection, there would be less influence. You would be focusing on new vistas, new part. You will form new connection, which with time will overshadow your quote unquote bad connection, your pain connection. And this is, again, with stroke, it's everybody understands. They don't see much problem with it. Yeah, sure, brain, you train something, but you do the same thing with other part of the brain, which not so obvious.
Mm-hmm.
Who knows what consciousness is, whatever, but it's not just consciousness. It's actual connection, which is responsible through central sensitization or whatever, actual connection is responsible for our unpleasant feeling of pain, unpleasant sensation of pain. It's connection. It's not, I say, phantom leg syndrome. You don't have a leg. So you form something, and psychedelic will help you to reshape and make it less important. And new connection would be just like with stroke. It's a new connection, new part of a brain. I can even predict what part of it, not very vaguely. I mean, it's
Sure.
not black and white kind of. But there are many, many connections. When you do fMRI in particular, it's not just one part. When we learn in anatomy in medical school, motor cortex, one part is responsible for finger, one part of the brain is responsible for leg, and sensor is the same thing. We have this actually oral anatomy book. It would be homunculus. It's like little men. Right. So we'll show. But this is easy to understand because that's why it's easy to understand post-stroke. It's much more difficult, much more diffuse to understand cognition because you're getting into area of consciousness. Lots of, not a lot, but anesthesiologists try to study this thing. If you have conceptually need to make it clean and start forming new connection, why not to put a person under general anesthesia for 3 days and then start de novo? And people thinking that of analogy, what anesthetic, how it works in relation to psychedelic, and probably, I don't know how much you're interested. One absolutely brilliant anesthesiologist in Michigan, his name is George Mashur. He's doing exactly that, trying to see EEG changes with psychedelics and versus anesthesia. So maybe it's up to something. But for now, all what we need to know is that psychedelic clear or gives the possibility to form new connection, new healthy connection, which with time will overwhelm so-called bad connection.
So we've been talking about classical psychedelics with a sort of like honorary mention to MDMA, which is not a classical psychedelic, but there's
correct.
a serotonergic, impact there. But there's some other psychedelics that you mentioned in your paper, and there's others that are presently being used for chronic pain. And when I say psychedelics now, it's kind of getting to this place where I had a researcher from Harvard, Nolan Williams, on the show. He used this term of splitters versus lumpers, where a lumper would be like, yeah, MDMA, ketamine, psilocybin, psychedelics, and a splitter would be like, no, technically psilocybin is a psychedelic and ketamine is a dissociative anesthetic and MDMA is an entactogen. Like, so going into this kind of like other realm of drugs often associated with psychedelics, there's ketamine, for example. I don't, like, you did mention ketamine a couple of times, and your mention of this anesthesia premise of putting someone over for a long period of time. Many years ago, I had read of somebody in some other country, can't remember, and they were treating chronic pain by putting people in basically a ketamine coma for 3 days or something like that, and that people would come out the other end and they would have significant changes in their chronic pain. I know now that ketamine, like at home, regular sublingual low dose ketamine, is being used as a treatment for chronic pain in some people. And in your paper, you mentioned PCP, which is also, like, PCP and ketamine are extremely closely related. And you've mentioned phantom limb pain many times. And I had a hard time like vetting the statement I'm about to make. Like, it all sort of tracked back to just like one specific paper or like one specific interview that I couldn't get back to, but that there was some history or discussion around a similar drug to PCP and ketamine called methoxetamine, MXE, also being used for chronic pain. So my question here is around, given what we understand about chronic pain now, what do you see as where ketamine and PCP, maybe MXE, like this class of drugs, fits inside of this model of treating chronic pain that you've discussed?
Yeah, let's start. PCP, honestly, I don't know much about this drug. It's not. Ketamine is approved for chronic pain treatment. In low doses, it's unclear exactly how it works, but we, like in our institution, people with chronic pain get infusion of ketamine, low dose, for about 4 days, 5 days, sometimes every day. And it works better than anything else for about 3 months, free of pain or free of perception of pain. It doesn't bother them, and then they need to go again. What exactly happening? It's difficult. No, it would be just my speculation. Really, I don't think it's proven. So ketamine helps to disrupt a connection which exists, but it's without psychotherapy by itself. It doesn't form a lot of new connection. It's so in 3 months, brain forgets what happened, and all this original structure start firing, and you need to repeat this therapy. Actually, right, with ketamine. It also has some significant component of dissociative analgesia, which means, what's your pain level? I'm dying, it's 10. You give ketamine, what's your pain level? 10, but I'm not dying anymore. I'm okay.
Mm-hmm.
Again, it's a kind of similar to cannabis in some way. It doesn't bother you. Exact mechanism of this phenomena I won't be able to explain you, but somehow, it's something changed in this default mode network. Somehow it changes, so you're not ruminating. You're not preoccupied this feeling.
Well,
But
if I could quickly interject, I know ketamine's sort of like, it's a very promiscuous drug on a neural level, but its main activation is through suppressing glutamate firing by binding to an NMDA receptor.
Correct.
So I assume that's probably part of it. It's like stopping the communication between body and brain. Or?
It depends on a part of a brain. The same glutamate receptor can be inhibitory, and so it's difficult to say. We have peripheral dopamine receptor, we have central, and they do function differently depending on circumstances, depending on a particular area of the brain. So ketamine, again, part would be dissociative anesthesia, but something to do with networks. It doesn't change transmission of a signal. Signal still getting there, but in a later part of a signal, transmission is stopped. It's way more complex than I'm just telling, and it's beyond even my understanding. I'm a clinician, and I know some of it, but I wouldn't be able to elaborate exactly what, any of these changes will affect what protein we start synthesizing. So any of these changes will affect creation of synthesis of new protein, new channels, and or removing channels out of circulation. So this also happening, part of connectivity, but part of actually signal transmission as well. So ketamine, just what you said, it's a dirty drug which works on many parts. The only thing I know for sure that whatever changes ketamine leads to, they're not permanent changes. So it comes back and you need to repeat treatment. It's unclear what would happen with psychedelic. It's not enough experience. Right now, yes, they do trials, and looks like even one dose was sufficient to change behavior up to 6 months. So something happening with the brain, which is I won't be able But seems to me more normal to expect that you will repeat this treatment, at least an initial portion of your disease, first year or two, whatever, you will repeat this treatment. And seems to me this would be make sure that our brain or we forget about so-called bad connection and our prevailing mode of operation. This default mode would not include default mode network would include only positive, but it will take probably some time when we will use psychedelics in combination with psychotherapy. So it would be more permanent changes. And maybe with time you would be less and less. If initially maybe every 2 months and every 6 months and every whatever for chronic pain or for probably similar to other condition. Actually, this probably good to bring point of addiction, which is one of the primary indication for these drugs, would be treatment of addiction in one form or another, opioid addiction or alcohol. They're trying for alcohol
nicotine,
addiction.
yeah. Or nicotine, yeah.
Right. So which conceptually it's chronic pain. You can some way say it's addiction to feeling bad about something and feel bad about life. So you need to change this addiction. So addiction would be another great area when you kind of need to remodel whatever connection formed with dopaminergic receptor. You need to break it and start de novo. So I believe it would be, but it's so obvious. Depression is much bigger term. And many reasons people, some of this grievance you're supposed to grieve. So it's to me, it's just such a big term, depression. Yes, I know scale psychiatrists do it by scaling. You have this, but there's so many aspects of it. PTSD and addiction, it's much clear.
You have like a particular sort of like thing you can point at. It's like, is this more or is this less? Where with depression, it's like so many possible areas.
True success with this drug initially, and if we have time, we can talk a little bit about company who developing this thing. But I think initial success would be absolutely shown for addiction and for PTSD. Chronic pain, the indication, but they're not through a randomized controlled study, which any of these companies which developing right now, it's kind of side effect of the development chronic pain. I believe it will work because it's mechanism of depression, like they kind of all wrong unnecessarily, people are not born to be depressed. Sure, there's some genetic component you can argue, but generally, we will develop this type of connection and this type of state. Very few people. It's anxiety. It's a different for teenage year, but through depression, it's a learned behavior. So treatment would be, we don't born with that. The same with chronic pain. It's a learned behavior, and we need to figure out how to unlearn it. Like PTSD was event which creates something, and now you have to unlearn and take it out of your default mode. And this is what psychotherapists generally try to do, it to kind of move out of this vicious circle of bad feeling, which create a bad connection with other people. I don't mean physical connection, emotional connection, and then it feeds back, and it's kind of feedback mechanism. You have to break it. Psychedelics, by changing this part, will, with help of psychotherapists, will help to reestablish your place in an outside, in a world. And by this, it's kind of positive feedback. More you have connection with your, friends, family, lovers, and things like this, more positive you would feel. It's kind of one thing leads to another.
Yeah, it's like the abundance of all the sort of like, quote, negative pain signals and the
Yeah.
compensatory sort of responses in your brain and stuff will limit, and also like you'd said, the sort of the unconscious reinforced learning of like hurting and expressing my pain
Yeah.
gets me care, like all of that will actually limit positive nourishing connections. And what you're speaking to is like getting more positive nourishing connections is itself good, but then and will like minimize the sort of like the pain stuff, but also the consequence of positive nourishing connections is actually sort of like overall good for your system and can help over even further
Yeah.
reduce the sort of pain signals. And that psychedelics can, on multiple levels, put us in a pathway to make that more possible, thus make it possible to pattern it into ourselves, making it more available, and then sort of like a
Right.
like an upward spiral.
It's all true, but with this thing, I don't want to ignore anti-inflammatory elements of the action, synaptogenesis element of the action, effect on descending. It's all there.
Yeah, it's all
It's
related.
all there.
Yeah.
But I think one of the main component why it would work, it because neuroplasticity and ability, our ability to relearn, think, and when the clear depression, so many connection, chronic pain also many, but something like PTSD and dependence, it's much more clear cut. So I think it would be first success we will see. Don't know, we already have successes. I mean, commercial companies developing, but this is one of the goal. Anxiety, difficult to define, but here it's kind of very defined event. Actually, with chronic pain, just 1 second.
Yeah.
With chronic pain, by alleviating comorbid condition like depression, anxiety, and PTSD, they indirectly affect perception of chronic pain.
Mm-hmm.
It will indirectly affect it.
Yeah. So what I'm hearing is, just on the whole, again, that classical psychedelics, anyways, in a context where they can be delivered in a multimodal, as a multimodal therapy. There's the pharmacotherapy of the drug, but then there's also the psychotherapy. There's all different elements all coming in together that psychedelics used in that way can seemingly help to have, potentially long-term positive reductions in chronic pain by working at all the levels that cause chronic pain to sort of like expand in and take, permanent sort of like residency in our lives.
Yeah,
right?
Yeah, it's right. Basically, it's correct. It works on, and each of these, like when I say anti-inflammatory, it's not fantasy. It's shown. It's the decreased level of pro-inflammatory cytokines. They call it. I don't think it's relevant. IL-6 and TNF. It's called tumor necrosis factor. And why I'm mentioning this too, because it's actual animal studies in rats when they show that psychedelics positively reduce number of these inflammatory mediators, and the same happening in the central glia and things like this. It's reduce number of these entities, cytokines or whatever it is, which is pro-inflammatory, and inflammation will lead to pain and things like this. So it's a real effect.
Mm-hmm.
No, I don't want. No, I'm emphasizing one part of it, but it's not so. This
Of
part,
course, yeah.
anti-inflammatory and inhibitory pathways, it's all real for psychedelic. It's proven with in animal studies and things like that. Obviously, psychological component it's impossible to study in mice and rats, but this part it's quite proven. It's not speculation anymore.
Mm-hmm. Yeah, and in that way, so you have this sort of like, hey, we have this thing that pharmacologically directly does these physical things that we want to do in order to treat in like chronic pain, and it also creates this other opportunity on the psychological end to sort of like, yeah, like hit all the beats that we could to sort of like, that we want to be able to do so to reduce chronic pain. I want to sort of like start to move towards a bit of a close.
Yeah.
Before I do, I want to say that there were 4 conditions that you talked about in your paper that you're like, okay, so these 4 conditions, I see these as being likely candidates. You know, you already talked a bit to cancer pain, so we could start to talk about that.
Yeah, it's exactly a good way to move this conversation. Let's start with fibromyalgia.
Sure.
Fibromyalgia characterized by widespread pain, fatigue, cognitive difficulties, sometimes they call it fibrofag, sleep disturbances. So it's kind of generalized disorder. Pain is everywhere, nobody knows where it's coming from. So this kind of disease, it's psychedelic kind of naturally fits into treating fibromyalgia. It's not actual injury, like diabetic neuropathy. Yes, you can put something topical. It will help you in some way. With fibromyalgia, nothing to do. It's just learning how to live and relearning. So I think if you will see success, and first success with chronic pain. No, right now they don't do this study. Right now they know about it simply from larger series. If people had fibromyalgia, they feel better, so you kind of assume. But I think this is a condition which is kind of tendency to use something like psychedelic fibromyalgia, and very similarly phantom leg syndrome. So there, this component of central sensitization and central component, it's a major component of this disease.
Because there is no peripheral nerves, because the leg
the
isn't
same
there.
with
The arm isn't
fibromyalgia.
there.
You don't have anything. You can put lidocaine patches all over your body. Nothing will happen. Right, so it should be very clear. The same with a little more complex with phantom limb syndrome. Depends where you cut it and say forming neuroma, but it's a main component. It's still in a central component. Another chronic pain in cancer patient, somewhat different. There you actually have stimulus. Let's say your tumor growing, close to your lung, then you will have a pain. It's kind of diffuse, but you actually need to treat pain as well. But also it's a feeling of doom, which is exacerbate your pain, feeling of, which I used was catastrophizing, and you said, yes, who should be? But it's not every cancer, it's end of the world. It's many curable. So you need to deal with this pain associated with certain cancer. Psychedelic in combination with nerve block or whatever you can do, depending where your tumor is and what's actual origin, it should be combination of this type of thing. I think it's a role, but if I say with fibromyalgia, it should be major component of the treatment. With cancer pain, it's in combination, because there you actually may have, source of pain. What else disease we mentioned?
Well, the last one mentioned was cluster headache, which I wouldn't say you need to go too far into. I actually have an entire interview with Bob Wold from Cluster Busters specifically about it. But
it would be great. I would be looking forward to hear your podcast on cluster headache.
For the listeners, like, to give us a general quick one though.
Again, a cluster, several mechanisms are implicated in cluster headache, and one of them, they call it trigeminal vascular network. Trigeminal nerve generates signals which is connect to a blood vessel in our meninges, which is structure which surrounds our brain, and one of the mechanism activation, and with psychedelics, they deactivate this pathway. We are, in a way, vasoconstriction of this vessel, a signal which goes from trigeminal nerve to whatever these vessels, somewhere mediated with serotonin, and by affecting this transmission, it leads to certain vasoconstriction. And where psychedelic will work, it's a breaking of headache cycle. And you can break this cycle. It's a more anecdotal observation, and will extend this remission period. It modulates hypothalamic activity and reduce inflammation, and there's some neuroplasticity involved with cluster headache as well. So kind of in broad stroke, this would be its use in cluster headache and migraine. Whatever studies people do, it generally in these 4 areas. I didn't choose it because, for a paper, we've been reviewing what literature available were clinical and some. It's not truly clinical trial. It's more series, observational, 20 patient, 12, whatever it is. But mostly, I say fibromyalgia leads itself into this type of treatment. Cancer pain in combination. It's not just psychedelics. Cluster headache, again, most likely it would be combination of
but also cluster
drug.
headache has we've got decades of people with cluster headaches that are reporting they have protocols. They've almost done the field research on themselves. So that's And
phantom leg, it's one of the most successful treatment is psychedelic, and both fibromyalgia and from whatever studies, and we list several studies which are available until 23 when we, I think end of 24, something, end of 23 when we've been doing searches. Most of this research is in 4 areas, so I'm kind of focusing on them. And again, 2 of them have if I have to guess, if I have to choose, if you ask me, what disease you would suggest to use psychedelic for, I will start with fibromyalgia and phantom limb syndrome. A little more complex with cluster headache. I would be looking forward to your interview, and cancer pain in combination with other therapies.
And I like to think that I am, I'm pragmatic. I'm a realist in a lot of ways, but I also don't want to lose the opportunity to sort of have hope and excitement for things either. I don't want to be so real that I lose the ability to dream. But in being realistic about psychedelics coming into medicine, there's a lot of concerns I have and some criticisms, but there's a lot of excitement and hope, especially for conditions that people end up suffering from their entire lives until they die from it in some way or another, that modern medicine has no good solutions for. And so, for example, cluster headaches is one of those things. And it's very exciting for me over the last year or two, seeing more of this research, and your paper being a great example of this condition or a collection of conditions that we have no really great effective solutions for, and psychedelics are coming in and being like, hey, this might be pardon the terminology here, but done well, if everything pans out, this might be a new lease on life that medicine has not been able to offer you. And having experienced long periods of pain in my life, and knowing people in my life who live with fibromyalgia or chronic pain, the idea that there could be an effective solution, on the near horizon, is something that brings me a lot of hope and excitement, and fingers crossed, fingers crossed energy.
Yeah, I think it's a good summary. I would say, in terms of chronic pain, moving from biological model of pain to biopsychosocial, this will kind of explain a lots of things what I was talking about, and the role of psychedelic. It's much more general, much more what's the right holistic, I guess, approach, and people understand this approach better now than it was, let's say, 50 years ago. Also, some visionaries, of course, they saw it in some way, not in relation to chronic pain, but the main thing for psychedelic would be a company developing like whatever mind. I don't want to list company. It would look like but it would be for condition like depression, anxiety, and things like this.
So at the very end of this interview, I'll encourage people to check out your paper, and I'll ask you if there's anything more you want to share from a how can people stay updated with your work kind of thing. But at the very end, like the last sort of main question is that, it's my assumption that there's a good chunk of people who will listen to this episode because they're sort of intellectually curious or they're academically curious, but there's probably a lot of people who will listen to it because they're hoping like, oh, maybe that's a solution for something that I'm going through. And I mean, realistically, anyone who wants to access psychedelics probably can. It's not necessarily in their best interest to do it outside of a supported context, but they may try it, they may not. But just assuming that psychedelics are not available for them and they haven't been finding success in what they're doing, and they're just kind of like at a loss, right? What would you sort of say to somebody in that situation if they came in and you only had 2 or 3 minutes to talk to someone to give them some sort of advice or perspective to sort of support them in their chronic pain journey? What would you offer? What would you say to them?
Yeah, outside of psychedelics, which is not available, but hopefully in a couple of years, looks to me, they would be approved by FDA. And when psychedelic approved for, or any drug approved for one indication, nothing stops you from using this drug for anything off-label. So this probably would be way to follow this development. And this company conducting through in collaboration with two institutions come to my mind, three. One is NYU, one is Hopkins, and one is San Diego UCSD. When they kind of in combination, in collaboration with the centers, it's a real serious trials. So it would be way preliminary data. Phase 2 shows that it definitely has effect. So it's expected in about 2-3 years we will have this drug available. The only thing my suggestion would be for chronic pain, significant component is biosocial, so it should be done with under supervision or neuropsychiatrist, psychologist, neuropsychologist probably would be better person, but something like this, somebody who could lead to form your new connection, new view of life. Your depression will go down, will be treated with this drug as a side effect or as a primary effect. Your chronic pain would be affected. Meanwhile, it's just multimodal approach. Never think about chronic pain as acute pain. It's such a different entity, but it's difficult to say because pain is one word. It's define everything. Define acute, define chronic, define
emotional,
heartache,
physical.
Emotional is a one. We just don't have this. Some languages do have different word for pain when your boyfriend leaves you or your girlfriend or whatever. They have a different word for this. We have one pain, but at least in this context, do not mix acute and chronic pain. So opioid, which is very helpful with acute pain, would not help you with chronic, and the same. So lots of combination probably way to go, and psychedelics, I am strongly believe, would be part of this multimodal approach, maybe central part, but it's not just by themselves.
Well, Dr. Alex Bekker, thank you for that. Thank you for your work. Is there a way people can follow you or your work with respect to chronic pain and psychedelics? Is this something that you are going to be continuing to write about or publish, other than following these centers that you just spoke about? Like, how can people stay up to date with this work and with your work?
Yeah, we in department where I am, we have labs which start doing experiment on mice with trying to understand connection. So and in the future when it would be approved, we have a pain center which we probably will start thinking how to use this drug. We use ketamine infusion now, but many places use it. It's nothing unique about that. For people in general, how to you probably when I can share my email, and they can just email me and with some question or suggestion or things like that.
Okay. Well, I'll be sure that that information, those links, contact is in the description of this episode, the show notes at jameswjesso.com.
Yeah.
Again, Dr. Alex Bekker, thank you so much for coming on the show today and for the good work that you're doing in the world.
James, thank you for having me, and I really enjoy our conversation. And your perception, it's make me believe that people, if you understand, that most people will understand exactly on the level of your understanding, which would be success.
Well,
thank you.
Thank you for that. And cut. Okay, that was this episode of Adventures to the Mind, episode 196 with Dr. Bekker. If you found his work interesting, I'll be sure to link his paper, Psychedelics as Novel Treatment Agents for Chronic Pain, Mechanisms and Perspectives, in the show notes to this episode, as well as the links to the various research centers he mentioned at the end of the interview there. Those show notes will be at jameswjesso.com, and a link to access them will be in the description to this episode. If you like what you heard here, please give it some sort of positive online engagement in some way or another, or share it with a friend. If you're interested in staying up to date with the podcast or what I'm doing, you can follow me on social media at Blue Sky, at jameswjesso.bsky.social, Instagram at ATTMind podcast, at Mind Podcast, or on Substack at James W. Jesso. Substack's super new right now, but I'm having really high hopes and good intentions for what's coming down the pipeline with my Substack moving forward. So if you're on there, consider following me there too. I also have an email newsletter and a Telegram. I don't want to bombard you with stuff here, so whatever way in which you want to stay in contact or stay in the loop, that'll be linked in the description. Finally, support for this podcast comes from listeners like yourself rather than brand deals or sponsorships or trying to chase the algorithm to hit viral content that makes it so that I can sell ads on that content, yada, yada, yada. It comes directly from listeners like yourself, so please consider supporting the show in that way. It helps me to earn a living while doing this thing that I love, and ideally, you also find at least some measure of value in. And as you heard me mention earlier in the episode, that comes through Patreon or one-time donations to the podcast through PayPal. I have an online shop where you can buy things like the books that I've written in digital format or physical format signed if you like, as well as other products if you are interested in getting some Adventures to the Mind swag in some way or another. But otherwise, PayPal or Patreon. And that's it. Yeah, this is the end of the episode. It's beautiful and sunny outside where I live here in Kitchener, Ontario. The springtime has fully sprung. The flowers are starting to bloom. The early bloomers are in full effect. I'm starting to smell things again. I'm starting to feel the literal light of the sun, ramp up the figurative light of my joy for life. Still pretty dim, but it's hard not to be in a relatively better mood when you exit the Canadian winter, the long, dark nights of Canadian winter into the beautiful sunshine of spring and summer. Anyways, did I need to include that? Probably not, but it's kind of how I'm feeling right now. Figure I'd share. And this is it. Thank you for tuning into episode 196 of Adventures to the Mind, and for tuning in all the way to the end. I appreciate that you chose to offer me your time and attention, and I hope that it was worth your investment. I've been your host, James W. Jesso, and until the next episode, take care and stay curious.